Okay, so now that we've looked at basically all the physiology, anatomy, and embryology of reproductive stuff, and we've connected it to endocrine, it's time to jump into the pathology, right? So keep in mind there was a huge thing about all the effects of estrogen, testosterone, and um, progesterone on everything, right? In the last video right before this, we talked about how progesterone and prolactin have communication with each other to kind of control lactation, right? We also talked about FSH and LH a lot, and we just saw that if a woman is now menopausal, that one of the specific indicators of menopause was really high FSH. Now, all of these guys are going to play, a lot of roles in the upcoming pathologies. So it's a little summary up here, right? Remember the interplay of FSH and LH for the female and male hormonal controls to understand how they will fluctuate in pathologies. In the female, which is on the left image here, the ovary, you can see the theca cells are affected by LH, right? They release an androgen precursor which goes into granulosa cells. FSH works on granulosa cells where aromatase then converts the androgen precursor into estrogen, right? And that's the female. In the male, right, the FSH goes to Sertoli cells and LH goes to Leydig cells. So you can see Leydig cells are pretty synonymous to theca cells in the female, and Sertoli cells are synonymous to the granulosa cells of the female. The Leydig cells release testosterone, whereas Sertoli cells are going to be the ones releasing this inhibin material, right? Inhibin and testosterone both have a negative feedback loop with the anterior pituitary. Testosterone also has a negative feedback loop all the way back to the hypothalamus, which is why if you're doping with exogenous testosterone, right, use of steroids to get stronger, that can stop the entire axis, right, stop the whole thing from working. So testes and ovary, you got to make sure you understand this basic layout of what cells are involved and what the hormones are. Then you can go ahead and look at all the reproductive pathology you need to. So sex chromosome disorders are the first thing we talk about, right? Aneuploidy, most commonly due to meiotic non-disjunction, right? Something went wrong in meiosis in one of the parents' gametes. So the first thing you have Klinefelter syndrome, okay? Male, 47XXY. You know it's going to be a male because there's a Y chromosome. So what are you going to see in these patients? Testicular atrophy, a unicoid body shape, right? They have this female body shape almost coming in, right? Because you could tell there's a bit of an hourglass shape going on right there because they are XX also. Long extremities, gynecomastia, female hair distribution, right? You can see the diamond shape right here. I mean the diamond shape or the triangle shape, whatever you want to call it. May present with developmental delay. Presence of inactivated X chromosome, which is a bar body, which is naturally seen in women, but it's going to be in anyone who has two X chromosomes. One of them has to be inactivated. Common cause of hypogonadism, seen in infertility workup, right? So a lot of these guys do look like a normal male, okay? And this is basically the number one cause of a man coming in telling you that he's infertile, right? And you do the checkup and you find out they're 47XXY. So what's their hormonal imbalance? The dysgenesis of seminiferous tubules leads to a decrease in inhibin B, right? If you don't have any seminiferous tubules, you're not going to release inhibin. Inhibin was supposed to go back over here and lower your FSH release. You won't be able to, so they're going to have low inhibin B, which causes high FSH. Similarly, without the Leydig cells, they're going to have low testosterone release. And so testosterone is supposed to go back and inhibit this and inhibit the hypothalamus. You won't have that inhibition either, so that leads to more LH, right? And more estrogen. Okay, so all of these things summarized right here from a UWorld snippet, where this is how questions present, right? UWorld snippets are going to tell you the scenario, or even your step one. The question is going to tell you a scenario of a Klinefelter syndrome patient, and then they'll ask you what hormonal imbalance you expect, and this would be the correct answer, right? High FSH, high LH, low testosterone, high estrogen. Okay, and this is another question regarding some of the phenotype stuff, right? Phenotype, the physical presentation of a patient with Klinefelter syndrome. So this one tells you a 15-year-old patient is referred to the physician by a teacher who's concerned about the patient's learning and behavior. The patient's reading and writing skills are significantly impaired compared to other classmates, and the patient often misbehaves in class despite receiving numerous detentions. Cytogenetic studies show a karyotype containing 47 chromosomes. which of the following findings are most likely to be present on further evaluation? So in this question, what they did is they really tried not to bring in the whole aspect of reproductive into it, and rather bring in the behavioral aspect, right, of being 47XXY. And you can see in first date, for example, they don't necessarily talk much about the behavioral aspect of being 47XXY. So this question kind of basically shows you the behavioral aspect that you can see in a patient that might be 47XXY. And the answer was just, once you figured out that, the 47 chromosomes must be 47XXY, you would just pick the physical presentation of a patient with Klinefelter: tall stature, gynecomastia, and azoospermia. Right? So, very important scenario to watch out for. Be careful, don't mess up, and just keep in mind that if this topic usually starts with the patient coming in complaining about infertility, if it's a mature person, if it's an adult. Yeah, man, I'm glad my work was able to help you, dude. There's a lot of resources online, but yes, it can be very difficult to find something to stick to and actually, successfully master topics and get through. So I'm very happy to know that I can help you, man. Alright, so that's Klinefelter syndrome, right? Straightforward, nothing crazy. Turner is a little more crazy. So Turner is 45XO, right? 45XO. So in this one, what's happening is you have a female, because there's no Y, right? So you're going to have a girl, and the girl is going to have a physical presentation that's mainly going to be affected by not just the outer presentation, but also the internal physical presentation, right? So let's take a look at the entire cocktail of symptoms and presentation. Short stature, if untreated, preventable with growth hormone therapy. Ovarian dysgenesis, so you're going to see something called a streak ovary, like this one here. Right, this is actually the UWorld image for this. So let me actually put it here and make it bigger for you guys to catch it. The picture they gave was just a real patient, but it doesn't really do the job necessarily. So the UWorld picture was a little better. Bicuspid aortic valve, coarctation of the aorta, right? Lymphatic defects leading to webbed neck or cystic hygroma and lymphedema in the feet and hands. Horseshoe kidney and a high arched palate with shortened fourth metacarpals. So now any of these things give you a lot of space for question, right? If your question is about a horseshoe kidney, then of course you have to remember this gets stuck, right, under the inferior mesenteric artery. You also have to remember there will be accessory arteries, right? There's going to be accessory vessels, blood vessels from the aorta for the horseshoe kidney. You have to remember the bicuspid aortic valve is a problem, okay, and that can cause different kinds of murmurs. Coarctation of the aorta was a really important thing in cardiovascular also. You have to remember that, of course, blood supply will go to the brain just fine, but not much of it will go down to the legs, right? And that's not going to work out. See, so upper limbs, the two hands and the brain are going to be supplied a bunch of really good blood, but the legs are not going to get it much, so there's going to be some kind of differential cyanosis you can see there. And of course, a femoral brachial pulse delay, right? The femoral pulse is going to be much less, no pulse in the legs basically, but a strong pulse in the arms. And on top of that, these patients are at risk of cerebral aneurysms because there's too much blood going to the brain. Okay, so that's something you have to keep in mind. What else was there? The ovarian dysgenesis, definitely a very high yield topic, right? That's going to be the ovarian dysgenesis with the streak ovary, right? You have to keep in mind that although this is happening in a patient, some of these patients can get pregnant, and you have to be ready for that. That can often show up in a question. So this is the most common cause of primary amenorrhea, and there will not be a bar body because they don't have the second X chromosome. Right? So this is a female without a bar body, and this one is a male with a bar body, both of which are opposite case scenarios. Menopause before menarche, basically they're born menopausal and they never really get their menarche. All right. Decreased estrogen leads to high LH and FSH, very similar to what's happening here, right? For different reasons. This one, XXY, there was high estrogen and low testosterone. Here they have low estrogen, which messes up their negative feedback, right? We're talking about this case scenario now. Without the estrogen, this feedback gets messed up, so they keep making more FSH and LH. Sex chromosome, either X or rarely Y, loss often due to non-disjunction during meiosis or mitosis. Meiosis errors usually occur in paternal gametes, right? So something went wrong with the father's sperm, and the sperm is going to be missing the sex chromosome, so the sperm came empty. Okay, so it's just, so this girl is born straight from the mother's X. Mitosis errors occur after zygote formation. Loss of a sex chromosome in some cells, but not all cells, will lead to a mosaic karyotype, right? And that means that some of the cells are going to be 45XO, whereas others might be 46XX. If something is wrong with the Y instead, that's actually more problematic, and this gives you space for a question right here. This is something that you can get a weird question on, right? If it's a 45X, 46XY mosaicism, that's associated with increased risk of gonadoblastoma. So you would have to remove the gonads prophylactically in such a patient. Pregnancy is possible in some cases of Turner syndrome, right? In vitro feted, exogenous estradiol and progesterone. You can do it, but generally speaking, it's still going to be a little hard, right? Because things are not normal in these patients. The hormonal balances are not normal in these patients. And pregnancy is very sensitive. Down here, I wrote more about the gonadoblastoma, right? So it's benign by definition, but more than 50% have coexisting dysgerminoma, which is malignant. And we're going to see some of these as we go on in the pathology section. Gonadoblastoma is a complex neoplasm composed of a mixture of gonadal elements, such as primordial germ cells, immature Sertoli or granulosa cells of the sex cord, and gonadal stromal cells. It is most often associated with the presence of a Y chromosome and abnormal chromosomal karyotypes. Turner patients with detectable Y chromosomes, if their issue was due to a mitotic error, where now they have 45X and 46XY, those patients should have their gonads prophylactically removed. The last two things, double Y males and ovotesticular disorder of sex development, these are much more rare, right? That's why when a question tells you there's 47 chromosomes, you usually immediately think of this one, unless they gave you a reason to think of 47 XYY, two Y chromosomes. Phenotypically normal, usually undiagnosed, very tall, normal fertility, right? So that's the big thing here. Normal fertility, whereas Klinefelter does not have normal fertility. The only thing with these people is like they're going to have two Ys, right? And you associate Y chromosome with excess testosterone in a sense. So maybe associated with severe acne, learning disability, autism spectrum disorders. Okay, but normal fertility. So they usually won't present until something of one of these three issues is becoming really problematic. And the last one, ovotesticular disorder of sex development, right? You might have a 46XX or a 46XY, either one of them, both ovarian and testicular tissue present, ambiguous genitalia, previously called true hermaphroditism. Right? And this is a more recent change. They don't really use true hermaphroditism as a thing anymore. So both ovarian and testicular tissue are present, right? Ovotesticular disorder. And this is pretty rare. I haven't really seen any questions on it. So throughout my reproductive chapter, though, I do have a lot of practice questions. We have a couple down here, and then after looking at all of these other pathologies, I have a whole page full of more questions to look at and revise stuff. So let's take a look at these first few UWorld questions over here. So we just talked about a couple things. Let's delve into how they'll present. So another Klinefelter question. 17-year-old boy is brought to the office for evaluation of bilateral breast enlargement. He first noticed it a few months ago and says that it is slightly painful. His parents are concerned that his breasts are gradually becoming more prominent. The patient is in special education classes due to a long-standing history of learning disabilities. Height is at the 95th percentile, and weight is at the 25th percentile for age and sex. Symmetrical glandular tissue is palpated under both nipple areolar complexes, which is now significant, right? Any 17-year-old boy could have bilateral breast enlargement, right? Because maybe he's just distributing fat in that manner. But when you start palpating actual glandular tissue, that's a problem. His sense of smell is normal, which is very important because that tells you it's not Kallmann syndrome, okay? And his testicles are small and firm. So we're seeing testicular atrophy, super tall, 95th percentile, right? And we're seeing some kind of learning disorder and glandular nipples. Labs would most likely show you what? You're going to see high FSH and LH, right? As well as higher estrogen, low testosterone, low inhibin B. This is Klinefelter syndrome. There's going to be a lack of feedback inhibition. The next one, 12-year-old girl is brought to the clinic by her parents who are concerned about her loss of interest in playing sports at school. During a recent competition, she walked off the field in the middle of the game, complaining about pain in her legs, right? So some sort of possible intermittent claudication. The patient has no other medical conditions and takes no medications. Vaccinations are up to date. Physical exam shows pulsatile vessels in the intercostal spaces and diminished femoral pulses relative to brachial pulses, right? So brachial femoral delay. And why does she have intercostal pulses? Because remember that if you have coarctation of the aorta, the thoracic arteries start becoming an alternate route for that blood to reach your descending aorta. So her symptoms are most likely associated with what condition? Turner syndrome. Right? She most likely has coarctation of the aorta, which typically affects the region just distal to the left subclavian artery. She has collateral circulation, as discussed on page 317. So let's just take a quick look at coarctation of the aorta. Right, good time to go back and revise that if you haven't looked at it in a while. Congenital heart diseases. Right, so coarctation of the aorta is right here, and you can see. This question here was teaching you that there's an increased risk of cerebral hemorrhage, like Berry aneurysms, because you're sending a lot of blood to the brain and not so much to the descending aorta, right? These are more images showing you what occurs. Right, coarctation in the aorta, you start using your intercostal arteries as a collateral way to go down using the internal thoracic artery and ultimately reach the descending aorta, right? A way around the coarctation. And this is, this image on the right is a more complex image. This one's showing you that coarctation can occur in different places based off of whether or not you have a patent ductus arteriosus also, right? So a patent ductus arteriosus would even further worsen things because there's even more deoxygenated blood going down. So that would make the brachial femoral pulse be okay, but the oxygen supply, the differential cyanosis that you might note, would be very different there, right? So that's kind of something right there. Of course, there's eroding of the ribs because there's too much blood under there. So we talked about all of that when we did cardiovascular, and this is just a tiny revision of that kind of stuff. So that was Turner. Next one, a newborn girl is evaluated in the nursery after an uncomplicated spontaneous vaginal delivery to a 29-year-old prima gravida. The mother declined prenatal testing and ultrasound exam during the pregnancy. Her pregnancy was otherwise uneventful, and she took prenatal vitamins. Exam of the neonate shows a posterior neck mass and bilateral non-pitting edema of the hands and feet, which is immediately a giveaway for the cystic hygroma in the posterior neck mass, and the non-pitting edema is just lymphedema. This is definitely a baby that was born with Turner syndrome. Femoral pulses are diminished because of the coarctation of the aorta. Neck ultrasound reveals a mass composed of a cystic spaces separated by connective tissue, which is the cystic hygroma. What is most likely underlying mechanism for this patient's condition, right? So they don't put Turner syndrome as an answer choice. They want to know the most likely mechanism. And they said it here, right? Meiosis errors usually occur in paternal gametes, right? You lose the paternal shit. So loss of paternal chromosome X was the correct answer, right? It could be loss of paternal chromosome Y too. The posterior neck mass is cystic hygroma, and bilateral extremity swelling is consistent with lymphedema. Diminished pulses suggest coarctation of the aorta, so this patient must have Turner syndrome, which is due to loss of the paternal chromosome, X or Y, doesn't matter. But the main thing is you lose the paternal chromosome. Last question here is a little more complex. So this one says a 6-year-old girl is brought in for evaluation of short stature. Her parents have noticed that she bears little resemblance to her two older siblings. The patient's mother and father are 5'8" and 6 foot tall, respectively. Right, so the father's pretty tall, the mom's tall too. On physical exam, the patient's height is 3 standard deviations below the mean for her age. Other findings include low set ears, high arched palate, webbed neck, cubitus valgus, all telling you that this is Turner syndrome, right? Even the chromosomal analysis 45XO. The patient is started on medication to improve growth and normalize her height. What intracellular pathway is stimulated by the medication used in this patient? Okay, so this is another really important takeaway, right? Right here we said that the short stature could be prevented, right? Preventable with growth hormone therapy, right? And now they're asking you a question that connects you back to endocrine, right? Asking you what intracellular pathway this utilizes. So let's take a look at the intracellular pathway this will realize, because remember, you need a map to grow, right? Always remember that. You need a map to grow. You need a map to grow your nation, or you need a map to grow your city, whatever it might be. So if you come back to the last page of endocrine physiology, you see all your signaling pathways of endocrine hormones and all your growth things, right? Insulin, IGF, FGF, PDGF, EGF, right? All of these growth factor things, right? These guys use MAP kinase pathways, right? And what are you going to give this girl for her treatment? You're going to give her growth hormone. So make sure that you keep in mind not to confuse these. Okay, the MAP kinase thing is for growing factories. I always think of like growing factories. You need a MAPS to get around your big ass factory. Right, so MAP kinase pathway would have been the correct answer choice if you were giving one of these things to treat her, but you're not. And a lot of people for that question had picked MAP kinase pathway. They got it wrong. But these guys, right, the piglet guys, prolactin, immunomodulators, growth hormone, granulocyte colony stimulating factor, erythropoietin, thrombopoietin, all of these guys are JAK-STAT. And in this non-receptor tyrosine kinase list, the hardest one to remember is growth hormone. So you have to make sure you remember it. You have to keep repeating it and reminding yourself. Growth hormone is, like you can see all the other hormones are kind of nicely distributed in cyclic AMP. And then there's a few harder ones to remember in IP3 because they're so random, like TRH and GnRH are right here. Those are really out of place. The other one that's out of place is growth hormone. Growth hormone is a non-receptor tyrosine kinase that uses JAK-STAT pathway, Janus kinase, and signal transducer and activator of transcription. That's what JAK-STAT stands for. This is your piglet stuff. And you can always remember this because I think of the JAK-STAT as acidophils and cytokines. And your acidophils are the PG, prolactin and growth hormone. Right, prolactin and growth hormone. Those are your acidophils from flat pig. Right? So the flat guys are up here, the PGs are down here. Okay, so non-receptor tyrosine kinase, JAK-STAT pathway is the answer for that. The other guy we have to remember from reproductive is oxytocin, and oxytocin uses GQ and IP3. So those are all your reproductive relevant things. So here the answer was just a JAK-STAT pathway, which obviously is a very good curveball of a question to confuse students and throw them off if you don't remember it. This patient has Turner syndrome, typically treated with growth hormone, which acts on the cell surface receptor to stimulate the production of IGF-1 in the liver. The cell surface receptor is a JAK non-receptor tyrosine kinase, which phosphorylates several tyrosine residues in the intracellular domain of the growth hormone receptor. That IGF-1 later on, that thing is going to use MAP kinase. Okay, but the thing used for treatment is growth hormone. And when you give growth hormone to treat them, and they tell you right here, growth hormone therapy, when you give them growth hormone to make sure at least, everything else that's wrong is going to stay wrong, but at least we can, help the girl be a taller girl, that growth hormone uses JAK-STAT. Okay, so that's your first few pathologies. Now on the next page, they go into more disorders of sex hormones, right, and sexual development. So this upper portion here is kind of summarizing the stuff they're going to talk about in the rest of this page, and you have to make sure you understand it. Okay, it's very confusing the first time you look at it. Not very. It's a little confusing the first time you look at it, but you have to make sure you completely get it. Now on the top, there's a little video I linked, so I'll share that in the chat right here. So that video does a good job kind of explaining sexual differentiation in case you're still struggling with it. But let's see what we see here. So there's 4 diagnoses they put here, right? Defective androgen receptor, testosterone secreting tumor or the use of exogenous steroids, and hypergonadotropic hypogonadism or hypogonadotropic hypogonadism, right? Secondary. What are these things all about? So on the left I explain, normally testosterone has a negative feedback on LH. But if the testosterone receptor is defective, it will not suppress LH. Right? And that's what you're seeing in the top. So testosterone and LH are both high. That means that the testosterone is not working on the receptor. In exogenous or excess testosterone, there will be an inhibition of LH. Wow, I used the wrong there. That's embarrassing. Anyway, I was probably typing too quick. In exogenous or excess testosterone, there will be an inhibition of LH, right? So you can see that right here. Testosterone secreting tumors, or if you're doping with exogenous steroids, you're going to have really high testosterone, of course, but that's going to work, and it's going to have a negative feedback on LH. Now, what are these two about, primary versus secondary? In primary hypogonadism, right, you don't have gonads. But there's something that's wrong. It says hypergonadotropic hypogonadism. There will be LH, but the gonads will not respond and make testosterone, regardless of LH, possibly due to Leydig malfunction. So you see how you're making a lot of LH, but you're unable to make testosterone. In both of these cases, you're unable to make testosterone because you're hypogonadic. Okay, but you have hypergonadotropic. This is because you're releasing gonadotropic hormones like LH and FSH, right? So hypergonadotropic is referring to the LH. Right here, this is secondary hypogonadism. In these patients, you have gonads, but you're not stimulating it because you're not making LH. Right? So this is hypogonadotropic versus hypergonadotropic. It's all about the LH here. Right? So these two cases are about the LH, whereas these two cases are more about the testosterone. Right? Make sure you understand that. It's not that complicated, but you might have to look at it a couple more times and maybe find some questions or something to get it down better. The middle portion of this page talks about other disorders of sex development. Right? So disorders of sex development, DSD. Disagreement between the phenotypic sex, external genitalia influenced by hormonal levels, and the gonadal sex, testes versus ovaries, corresponds with the Y chromosome. Includes the terms pseudohermaphrodite, hermaphrodite, and intersex. So there's 46XX and 46XY disorders of sexual development. In XX, obviously you're not going to have testes, right? That's what you're thinking. So ovaries would be present, but the external genitalia are virilized or ambiguous. And there's many reasons this can occur. Right? 46XX, so this is a female, but for some reason her external genitalia don't look right. Well, why would that occur? It could be due to excessive and inappropriate exposure to androgenic steroids during early gestation, such as in some congenital adrenal hyperplasias, like in 21 and 11. Right? 21 and 11, both the second digit is a 1 pointing upwards, which tells you that testosterone is high. So in 21 and 11, the female might be born with ambiguous genitalia. It could also be due to exogenous administration of androgens during pregnancy, which, why would you do that? That's fucked up. The next one, 46XY disorders of sexual development. This is going to be a male, right? They have a Y, so this is going to have a testes present, but the external genitalia are female or ambiguous. Why would this occur? Well, this can occur if, one, you don't have enough phyloreproductase, so you're not making DHT. It can occur because you don't have enough testosterone to begin with. Okay. Most common form is androgen insensitivity syndrome, testicular feminization. Right? Androgen insensitivity syndrome. So you're making androgens, but you're not responding to it. And we're going to see more about that down here. So disorders by physical characteristics, right? And this is very important because this is kind of how your questions are going to be. They'll tell you a patient came in, what's there, what's not there, and then you can pick the correct disorder. So if a patient comes in and they have a uterus, but they do not have breasts, what does that tell you? Well, having a uterus pretty much confirms they are XX. But no breasts, well, breasts are a sign of secondary sexual development. So it could be either one of the hypergonadotropic or hypogonadotropic hypogonadism. Point is, it is definitely a hypogonadism because you're not making enough estrogen, or, otherwise if you had enough estrogen and progesterone, you would develop correctly. Right? So that's all that falls under here. If you do not have a uterus, but you do have breasts, uterovaginal agenesis in genotypic female, or androgen insensitivity syndrome in a genotypic male. It could be either one of those. Either one of those. So you would have to check what is their genotype. Are they XX? Are they XY? Right? If it is an XX patient with no uterus, it could have been Mullerian agenesis, for example. Right? And if it's an XY patient with breasts, that could be androgen insensitivity syndrome. If you don't have a uterus or breasts, that should be a male, right? So male genotype with insufficient production of testosterone. Right? Pretty straightforward stuff. None of this is very confounding. It should totally make sense. Now we can look at some of the final deficiency and syndrome stuff. So we talked about placental aromatase deficiency in the last two videos, right? We looked at an image where you could see that the lack of aromatase made it difficult for you to convert androstenedione and testosterone into estrogen. And now all of that excess testosterone was going both ways. It was going to the mother and causing hirsutism and other excess testosterone symptoms in the mom. And it was also going to the fetus. And if it's a female fetus, you're going to have masculinization, right? And that's what they're explaining here. Masculinization of a female infant, so you can get ambiguous genitalia, high serum testosterone and androstenedione, can present with maternal virilization during pregnancy as well. Okay, so it's very, very key kind of thing. They will most likely tell you that the mother is having masculinization symptoms as well, and that's going to be your cue to pick aromatase deficiency. The other one, androgen insensitivity syndrome, right? AIS. They told you right here that androgen insensitivity syndrome is pretty much the most common thing, right? Most common form is androgen insensitivity syndrome if you have an XY with some kind of sexual development disorder. Defect in androgen receptor resulting in normal appearing female, right? But they're actually 46XY. Okay, so it's going to be these questions are usually pretty funky because the question is going to start with telling you something like a mother brought in her daughter, right? But it's a patient that's XY. Okay. Female external genitalia with scant axillary and pubic hair, rudimentary vagina, uterus, and fallopian tubes are absent because it's a male, right? Patient developed normal functioning testes, which are often found in the labia majora and are surgically removed to prevent malignancy. This patient will have high testosterone, estrogen, and LH, right? Because it's not a sex chromosome disorder, they just have androgen insensitivity syndrome, right? Because the main thing to take away here is that they have high testosterone and high LH, right? Because all that testosterone is not working, so that's why they developed into a very female-appearing body type, and the LH is not being shut down. No negative feedback there, right? So very, very funky type of question to watch out for. Usually the question starts off by saying that her mother brought in her daughter because she still hasn't menstruated and she's 16 now or she's 15 now. And of course that is a cause of concern. So then you look at the patient, you do all your tests and you find out that they have high testosterone and high LH. That means that they are not a female. This is actually a son, right? It's a male patient with androgen sensitivity syndrome. It's a very funky type of question. I also wrote both LH and testosterone high due to a lack of negative feedback. The lack of pubic hair is very significant and differentiates this from other conditions like Mullerian agenesis, where the 46XX female patient looks the same but has pubic hair. Right? Remember here they tell you scant, very scarce amounts of axillary and pubic hair. They don't have much pubic hair at all. That's androgen insensitivity syndrome. Okay. In Mullerian agenesis, the patient has the same issue, right? The patient presents looking like a girl, but might not have, not have uterus and fallopian tubes and stuff. So at that point, you want to think, okay, what's happening? How much pubic hair is there? What are the hormonal imbalances? Although male, they get raised as if a female, right? Breast development occurs thanks to aromatase and adipose-making estradiol. AIS, androgen insensitivity syndrome, is an X-linked defect of the androgen receptor. Masculinization won't occur due to androgen resistance. Next one, 5-alpha reductase deficiency. Very straightforward thing, right? Autosomal recessive, sex limited to genetic males, right? 46XY, disorder of sexual development. Inability to convert testosterone to DHT. You're going to have ambiguous genitalia until puberty, so it's not that big of a deal. After puberty, when testosterone levels get really high, you start seeing more masculinization and growth of external genitalia. Testosterone and estrogen levels should be normal. LH is also going to be normal because there will be feedback. Internal genitalia are also normal. So for the most part, everything is going to be normal. So on the left, I have a little thing. It says a 17-year-old girl has never menstruated, has facial hair, clitoromegaly, curly pubic hair, and no breast gland. Ultrasound shows inguinal testes, but no ovaries or uterus. 5-alpha reductase deficiency. This person is karyotypically male XY but lacks DHT. Okay, so you got to make sure you can kind of understand that stuff. Right, this question that I kind of put as a quick summary on the left right there, the answer was 5-alpha reductase deficiency, but it looks a lot like it might be androgen sensitivity. It could be Mullerian agenesis. It could be any of those, but they have curly pubic hair. Right? Remember, AIS, androgen sensitivity syndrome, does not have much pubic hair. On top of that, she also has facial hair, right, and clitoromegaly. So, this is all showing you that there's a lot of testosterone there, right? It's just not becoming DHT. And if she's 17 and never menstruated and doesn't even have ovaries, it's not a girl. It's a guy, right? The parents misunderstood the gender of their child. Most of these are kids that were born in another country, not America, so the gender wasn't exactly identified at birth by actually checking blood and whatnot, chromosomal analysis. So you want to make sure you can pick out what's happening, right? Ultrasound also shows inguinal testes, not that the testes are in the labia majora, right? So be very careful. No ovaries or uterus, it's not a female. It's not a female. Right? That means that it's a male, and this is a male with no DHT, lack of 5-alpha reductase. This is also a 5-alpha reductase question. This one says a 22-year-old primigravida who recently immigrated from the Dominican Republic has a normal vaginal delivery. The infant is phenotypically male but has hypospadias, a small phallus, and his testes are well developed but in the inguinal area. So they haven't completely descended into the scrotum. Serum testosterone is normal, as well as his blood pressure. What enzyme is most likely deficient? Reproductive. Once again, same thing. Right, so the inguinal testes is looking like a common repetitive case scenario with reproductive deficiency, and you want to make sure you can catch that, right? Inguinal testes. So let me just put that in red because that's another thing that's pretty significant, and they didn't really point that out, right? No. Okay. So that's pretty good. Last thing on this page, Kallmann syndrome. Kallmann syndrome. So Kallmann syndrome, the main thing is going to be lack of being able to smell things. Okay. Failure to complete puberty, a form of hypogonadotropic hypogonadism. So they're not making LH and FSH, right? No gonadotropic hormones, gonadotropic releasing hormone. So GnRH causes the release of more LH and FSH. This is going to be hypo. Defective migration of gonadotropic releasing hormone releasing neurons, and subsequent failure of olfactory bulbs to develop. So now you have decreased synthesis of GnRH in the hypothalamus, and you have practically anosmia, an inability to smell things. These patients are going to have low everything, GnRH, FSH, LH, and testosterone. Patients will be infertile due to low sperm counts in males and amenorrhea in females, because again, no FSH, no LH. And one extra note I added here is FGFR1 is inactivated, which manifests in Kallmann syndrome with disproportionately long arms. Right, so that's something that you can see in a question. Be very careful to not miss that. At the bottom, I have a question related to Kallmann syndrome from UWorld. So this one says a 14-year-old boy is brought in by his mother. She's concerned because although tall, her son looks much younger than his peers and shows no signs of masculinity. On physical exam, the boy has poorly developed secondary sexual characteristics. He is unable to distinguish smells, but has good visual acuity. The visual acuity part was just there to throw you off. The main thing was he can't smell shit. What hypothalamic pituitary gonadal pathway is most likely defective? And that's going to be the pathway that releases GnRH. Right? He has Kallmann syndrome, which is due to a failure of GnRH secreting neurons to migrate from their origin in the olfactory placode to their normal hypothalamic location. Most often, it's due to a mutation in the Cal1 or fibroblast growth factor receptor 1 gene. And that's what I put here, the FGFR1 gene. Right? When that gene gets inactivated, it affects your growth of your arms and stuff too. So the phenotypic presentation is always given in these questions, and they're going to try to throw in as much extra shit they can to confuse you. So be ready for that. Right on the left is a little table to kind of help you summarize all the differences of things we just looked at. And just spend some time today making sure that you're able to understand all of these differences in combination with, where are we? In combination with this stuff, right? So, this table, where is it? Oh, was it even earlier? It was earlier. Yeah, this table right here, right? In combination with this table. So sexual differentiation. Make sure that by this point you've memorized this table perfectly. You understand what the errors can be here, right? The differences between where the internal stuff is coming from, right? Testes versus ovaries really depends on the chromosomes you're born with. Testes and ovaries. After that, the testes or the ovaries are the guys that decide whether your Wolffian duct is going to become something or your Mullerian duct is going to become something, right? And the external stuff is just naturally going to come directly as a result also, okay? So where things can go wrong, you have to make sure you understand that and combine that with the pathology that we just studied today as well, right? Get all that down, and then in the next video, I'm going to start it with a whole page of a bunch of questions from AMBOSS and UWorld, both relevant. Actually, these are all AMBOSS questions relevant to the stuff we just looked at. All right. So thank you very much for joining. Keep studying, and I'll see you guys again very soon.